Hello and welcome to our presentation on substance use disorder. We just wanted to begin by acknowledging and respecting the Lekwungen, Songhees, and Esquimalt peoples on whose territory this university stands, and the Lekwungen and Wasanish peoples whose historical relationships with this land continue to this day. So here is our presentation overview. My name is Ben, and I'm going to be doing the first section where I'm going to talk about the history of substance use disorder, services, and prevalence within Canada. So as I mentioned, our main health issue is substance use disorder. Substance use disorder, or SUD, is the use of illegal prescription or over-the-counter drugs or alcohol for the purposes other than those they are meant for or in excessive amounts. It's a major health concern in Canada right now and requires a lot of attention and action to address these overdoses as well as expand our treatment. It's a large and growing health issue. It's estimated 21% of Canadians will meet the criteria for addiction in their lifetime. And with addiction, the main problem is overdosing. So as we can see, 1999 to 2021, there were over 645,000 overdose deaths within Canada. That's a huge number and one that affects a lot of members of the population. Specifically, opioids are a problem. So between 2016 and 2023, there were over 40,000 opioid-related deaths in Canada, which is an average of 22 deaths per day. So as we can see, this is a large stress on both the Canadian healthcare system as well as public safety. On this slide here, we just have a few more statistics that we wanted to highlight of the prevalence of substance use disorder in Canada. I did want to just highlight this one. The alcohol abuse leads to 4% prevalence of fetal alcohol spectrum disorder. This stat was brought to us from the Truth and Reconciliation Commission of Canada, which has a list of calls to action from the government. And one of those calls to action is to address and find more resources for the prevalence of fetal alcohol spectrum disorder in the Indigenous population within Canada. So as we can see, this is an issue that's being tackled on multiple fronts. And then as well, there's, as we know, issues with cannabis and psychoactive pharmaceuticals. And the stat down here, 3% of Canadians use illegal drugs regularly, as we learned in Health 301. This does have a large public health impact. It increases the risk of bloodborne diseases and burden on the healthcare system, which can overall have a negative effect. I just want to turn to the history of substance use disorder in Canada. So it all started in 1500s to 1800s when fur traders and colonizers introduced alcohol and other illegal substances to these indigenous communities. These were exchanged at trading posts for valuable items such as furs. In 1839 was when we saw the Opium Wars being fought. So this was a war that resulted in an increase in trade activity because, there was the availability of opium from India and China to be exported into North America. In 1908, Canada signed the Opium Act, which prohibited the importation and sale of opium. While this might initially seem like a great thing for public health, it was actually motivated by racial prejudice rather than public health. So there were many reformers that were successfully branding opium smoking as foreign and a dangerous habit linked to the threat of the white man, was what was once said. So this framing shifted public opinion against opium for these religious and racist reasons, which is one of the reasons why we've had horrible treatment of many cultures within Canada's past. As we know, Chinese people were forced to pay head tax, and Indigenous peoples were seen as a danger to society. As we learned in Health 301, this was also the beginning of institutionalized treatment of Indigenous individuals. Canadian and North American suspicion of foreigners increased through World War I and World War II, which led to, in the 1940s, anti-drug campaigns, which was really the start of the stigma and discrimination. So addiction and substance use disorder was thought to be criminal, and there was this concern around this criminal addict, which led to this negative public health opinion. So moving forward to the 1960s, that was when we had a large counterculture movement. So there was political and social change centered around drugs and sex and caused large increase in consumption of cannabis and narcotics. At the same time, policy changes saw the Narcotics Control Act forcing its illegality and also made it legal to discriminate against people who use drugs. Fast forward to the Ledane Commission, which was signed in Canada, actually attempted to switch from discrimination to an approach where the government could help people recover from addiction. So this was the first recommendation that we have seen that medical treatment should be given to individuals addicted rather than criminal punishment. In the 1980s, this is where we first saw the harm reduction approach begin and the first needle exchange programs that we know today. And then 1995, Canadian Addiction Treatment Centers are founded, and this was, further displayed our war on drugs. Indigenous treatment programs specifically were a way that the government could show our support and recognize that a change needed to be made between rural and underserved communities within Canada. So fast forward to 2023, and we have the first official supervised injection site opening within Canada. This was nurse supervised, which gave users a safe and legal way to use these drugs. In 2013, as we can see by these graphs here, we have a new wave of opioid overdose deaths, mainly due to the increase in fentanyl. In 2016, there was a big step forward when Health Canada announced that naloxone could be proactively distributed. This is a life-saving medication that was previously only available at these injection sites, but now individuals could use it safely at home. And then that brings us to 2024, where some provinces, adopt a recovery-oriented systems of care, which Sarah will talk about later, which provides a more holistic addressment to the impacts of substance use disorder in Canada. While substance use is still widely prevalent and continues to need public health officials, we are stepping in the right direction, which we will get to later in our presentation. So thank you very much for listening, and I'm going to pass it over to Nick, who is going to discuss his section on barriers and accessibility.
Hello, my name is Nick Bartamucci, and I'll be doing barriers and accessibility. Barriers to addiction treatment are obstacles that prevent a simplistic addiction recovery process. As for the recovery-oriented approach, these barriers can prevent people from making their own choices for addiction help due to there being long wait times, rural access and transportation, indigenous access and discrimination, funding, and stigma involving addiction treatment. These barriers produce inequalities when it comes to how much support someone can receive, creating mixed assumptions and biases on whether addiction treatment is a possibility. Wait times are a barrier responsible for postponing people's approach to addiction treatment. Wait times are the amount of time it takes for same-day or next-day appointments. In a recent study on wait times at a low-barrier access addiction clinic, it was found that 23% of patients waited until the next day, leaving 53% of the next day patients seen overall. Roy and colleagues also found that 30% of patients had to wait over 2 days, leaving only 39% of that 30% being seen. They also stated that patients who were scheduled same day and next day are more likely to attend addiction treatment in comparison to those waiting longer. To add to a longer wait time, people from rural areas also sometimes face the problem of long and delayed travel times. This can be overwhelming for some, whereas some rural areas have medical support and addiction clinics while others may not. Having a delayed appointment while traveling out of town can bring many financial complications. Rural areas may lack the funding and overall resources needed to supply addiction clinics. This leads to the issue of transportation, an expensive and complicated solution for some as rural areas can be hundreds of kilometers away from these treatment centers. The differences between rural and urban treatment centers have shown to have a large difference in quality. In an assessment by Edmond and colleagues, rural treatment centers were most likely to be all or none of nonprofit organizations, dependent on public funding, offered fewer treatment options, and reduced access to experienced counselors. These factors in rural communities were found to be subject to resource availability. Many rural areas are made up of indigenous communities, which have been shown to experience discrimination and limitations for addiction treatment access. In a recent study on barriers to healthcare services, McConkey stated that most indigenous access barriers are the social determinants of health. In her article, she discussed with physicians that in a lot of these cases, it is mainly due to resource scarcity. She also found that newer physicians who were offered these jobs to fill in more medical space in rural areas are mostly new to the medical field. This would support how indigenous communities and rural areas yield the same results when it comes to access to addiction treatment. In terms of discrimination against Indigenous peoples, McConkie mentions improvements that need to be made to lower the barriers. Some of these are additional cultural awareness for physicians, better access to transportation, and awareness and communication between community support and hospitals. These factors would help with social coordination, as there seems to be a lack of coordination between services. Transportation is also not considered, as referrals are unable to be completed due to complexities in community support. Reserves are also less supported with modes of transportation such as buses, trains, and taxis, which is a larger barrier compared to a city. To prevent discrimination and promote easier transportation for Indigenous communities, there needs to be additional funding to support every individual with access to addiction treatment. This funding can go towards educating physicians on cultural awareness, as well as building more local facilities to jump the transportation obstacle. For a community to support the population, proper health care should be mandatory. The stigma surrounding mental health disorders is due to the negative context surrounding substance abuse. This misinformation is typically spread by words or comments involving suffering individuals. In an article on the stigma of substance use and disorders, it is stated that organizations realize that people's language, treatment, and policies need to change for there to be an improvement in the public health crisis, by Zwick and colleagues. Language involving people experiencing addiction can also lead to barriers in things such as employment, insurance policies, and healthcare. These barriers accelerate the crisis and can be limited by different language choices that will change social acceptance within a community. The stigma of seeking help exists because of the embarrassment and fear of seeking medical attention. When it comes to addiction, it can be severely challenging to search for resolution. This can be caused by embarrassment, assumptions, fear of help, or fear of medical professionals. There is evidence that people feel embarrassed about seeking assistance for mental health disorders such as depression and addiction that was found in a study by Barney and colleagues. That same study also found that people expect medical professionals to respond negatively. Due to the negative context surrounding addiction, it is often assumed to be a choice rather than a mental health disorder. This stigma is unfortunate, but can be overcome with education, compassion, and proper language.
Hi, my name's Evan, and I'll be talking about the social determinants of health. So, the social determinants of health in Canada refer to the social and economic factors that impact one's well being. So, these include things like income, education, employment status, discrimination, racism, and historical trauma. And one small change in any of these determinants can cause many shifts in one's health status. So, addressing inequalities like income, housing, education, and more should be a priority for people working in the health sector in Canada. So diving deeper on the topic of the social determinants of health, we look at the inequalities between Canadians. So health inequity refers to the inequalities that are unfair or unjust and modifiable. So these things could be caused by genetics, behavioral choices, but they're often caused by the social determinants of health, which are not directly in one's control. So for example, Canadians in Nunavut have little to no access to low-cost nutritious foods because they live in Nunavut, not because they choose to shop at expensive places. Health equity is the absence of unfair systems and policies that cause inequalities. So developing health equity requires evidence-based data, engagement on the interpersonal community and legislative level, and clear communication of health-related information across Canada. So substance use disorder is often linked to determinants such as low income, lack of employment, and low education levels, as we can see in this next slide here. So in these three graphs, there's a clear difference between one group and the rest of them. So in the first graph on the left, we can see that people who do not have a job often smoke more than people who do have a job. In the middle graph, we can see people who have a university education often smoke less than people without a university education or less. In the graph on the right, we can see people who identify as Indigenous often drink more alcohol on average than people who are non-Indigenous. So these might not be much of a statistic on their own, but if we look at the social determinants of health, we can see that there are some correlations. One of the social determinants of health is being Indigenous. Indigenous people with jobs in Canada earn less on average than non-Indigenous people. The unemployment rates for Indigenous people are 2 to 3 times higher than non-Indigenous Canadians. The lack of affordable housing and lower income rates has caused overcrowding of homes and several health problems such as poor mental health and substance use. So in this table here, we can see that the dwellings on reserve require much more major repairs than Canadian dwellings off reserve. And what this means is that people who need the repairs have to fork out money out of their pocket to afford these expensive major repairs, which limits their financial flexibility, so they have to do these major repairs first before they can focus on other things like spending money on treatment for a substance use disorder if they have one. So from the social determinants of health, we'll move into the current services and emergence of recovery-oriented systems of care, presented by Sarah.
Okay, so now we're going to dive into some current services that are being implemented in Canada to address substance use disorder. Specifically, we're going to talk about the emergence of a recovery-oriented systems of care. So traditionally in Canada, there's two main approaches you hear to treat substance use disorder. You hear of a harm reduction approach and an abstinence-based approach. But what's gaining significant attention around the world is the emergence of a recovery-oriented systems of care. And what this does is it recognizes, as we've noted in this presentation, that substance use disorder is not an individual issue and thus cannot be treated at the individual level. So since there's so many societal factors that are impacted and contribute to substance use disorder, we have to look at treating it at a larger scale. So what a recovery-oriented system does is it empowers the person to address a wide range of needs outside of their substance use in order to build a meaningful, hopeful, and successful life. So that looks like supporting housing, employment, education, physical, mental health, and so on. So one particular government in Canada that is adopting the systems of care is Alberta. So they have introduced what is called the Alberta Recovery Model, and in this they have made a commitment to 10,000 new publicly funded addiction treatment spaces, the elimination of daily fees for treatment, which directly addresses that waitlist barrier that we highlighted earlier in the presentation. It also, the next point, provides treatment on demand through a virtual opioid dependency program, which has already shown great efficacy, especially for those in rural spaces, as we highlighted was another barrier for people seeking care. Supportive health implementations, licensing and quality of standards, and the implementation of my recovery plan, which I will go into further detail about in one moment. But what this shows is that Alberta, through adopting a recovery-oriented systems of care, has made great strides in improving addiction treatment accessibility while expanding mental health supports. One concept that is central to a recovery-oriented systems of care is recovery capital. And recovery capital emerged as a concept in 2008, and it is defined as one's internal and external resources that can be drawn upon to initiate and sustain recovery. So there's social, human, physical, and cultural components that play into this, and essentially it's just a broad way to look at social determinants of health and really break them down. So that's through those quality of relationships and mental health, and that's through income and socioeconomic status and cultural positions and so on. So recovery capital is really central to this because governments, through the literature on recovery capital and sustaining recovery, governments, including Alberta, know that by building and promoting recovery capital within communities and workspaces and in homes, that individuals will more likely be able to initiate and sustain recovery. But how do we track this? So, as we highlighted, Alberta has committed to publicly fund a platform called My Recovery Plan in their publicly funded treatment spaces, which is a new digital healthcare assessment and recovery management solution that looks to revolutionize addiction healthcare. So essentially what it is a online service where you track an assessment of your recovery capital, so a way to quantify broadly your social determinants of health. And you can track it at intake for inpatient treatment, at discharge, and then at 3 months, 6 months, 9 months post-discharge. So it's a way not only to see are people getting treatment, but it's a way to see are their lives actually improving. And the long-term goal of this platform is that we can integrate social services with my recovery plan. So if somebody reports low on housing, then we can allocate specific resources to meet people at their needs, because it recognizes that recovery is only possible when people's broader social determinants of health are supported. And also, as we learned in class, there's different levels of healthcare. My recovery plan reflects a tertiary form of healthcare, as it's a specialized service typically offered in inpatient settings. And lastly, we just want to draw on the collaborative efforts of the Alberta model of recovery and recovery-related systems of care. So in June, they initiated an Alberta Recovery Council that collaborates with a variety of different people to work together towards a shared vision of a recovery-oriented care. Specifically, I want to highlight in this, as we've seen, there is a major barrier for Indigenous people to access care and receive equitable health care. So a major part of this is they're partnering with First Nations to build recovery communities, as well as we saw in an article by the National Collaboration Centre for Aboriginal Health that we read in class. It stated that healthcare must be accessible, available, and acceptable. And furthermore, it stated that acceptability of healthcare requires that Indigenous peoples are collaborators with the health providers and a part of the process. So this just goes to show that Alberta's model is working towards that to ensure more accessible, available, and acceptable healthcare for those impacted by substance use disorder.
I will now discuss the takeaways of this assignment. Throughout this assignment, we have learned the history of substance use and how it has been viewed by society over the years. Barriers including stigma, wait times, and low recovery capital limit access to care. The social determinants of health play a significant role in the well-being of individuals. It can impact their access to care and health status. We have learned that a recovery-oriented approach is a holistic method of combating substance use disorder. It includes pursuing and maintaining recovery with the help of internal and external resources. Previous approaches have focused on acute interventions to manage the negative effects. While this is still prevalent, there is more to substance use than its negative effects. Throughout this course, we have learned relevant knowledge that relates to our topic. The recommended essential functions of a public health system include health protection, health promotion, health surveillance, disease and injury prevention, and population health assessment. Health protection includes interventions to address negative influences on health. Health promotion includes mental health promotion, encouraging the development of socially supportive environments. The Canada Health Act advocates that the primary objective of Canadian healthcare policy is to protect, promote, and restore the physical and mental well-being of residents of Canada and to facilitate reasonable access to health services without financial or other barriers. Despite these frameworks and essential points, there is still inaccessible care for Indigenous peoples due to health system deficiencies, geography, and inadequate human health resources. There are also historical traumas, stigmas, and biases that may influence a substance use disorder and accessibility to support and treatment services. How can we build on this? We want to ensure culturally safe and patient-centered care. This ensures quality of care being free from bias, stigma, racism, and discrimination. We feel that it is important to work with the marginalized group as collaborators for ways to combat health issues together. This includes working with individuals who have experienced or are experiencing substance use disorder. We must improve accessibility through elimination of barriers. The CSSA reports 47.1% of individuals in their Life and Recovery survey face barriers when beginning their rehabilitation. We can eliminate these barriers by providing more quality programs and support within communities culturally diverse programs, and more language option services. Social determinants that impede health must be addressed in order to ensure long-term, consistent care. This includes access to housing, clean water, food security, education, and employment. We want to advocate for recovery-oriented approaches to ensure support and maintenance of an individual's recovery. We have developed some personal statements that we would like to share. Ben, as someone who aims to have a future in healthcare, HLTH301 has given me invaluable insights into the positives and shortcomings of the Canadian healthcare system. This will allow me to approach patient care with cultural sensitivity, advocate for equitable access, and contribute meaningfully to improve health outcomes within diverse communities. Nick, after doing extensive research on substance use and addiction, my knowledge on addiction disorders has significantly grown. Equal access to medical help for individuals with mental health disorders remains uneven, presenting an opportunity for my future career to promote awareness and advocate for equality regardless of individual differences. Evan, researching about substance use disorder and its proximal and distal determinants has given me great insight into how complex and interconnected Canada's healthcare system is. Knowledge I gained from the first 9 weeks of this course will continue to help build and develop the relationships and attitudes that I have with my peers. Tiana, this topic and class altogether have extended my knowledge to the disparities that exist within Canadian public health. I have a better understanding of the impact of social factors on health and would like to advocate for change and improvement in this regard. Sarah, through HLTH301 in this project, I have gained a deeper understanding on the operations and complexity of health systems in Canada. As someone who is currently conducting community-based recovery-oriented research, I've gained insight to accessibility, inequity, and systemic barriers and considerations that cannot be overlooked both in research, policy, and in practice. Here we have listed resources that can provide more insight or direct you to a service. Thank you for listening to our presentation.